The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Okay, we now move on to pediatric rheumatology. Whenever you encounter a question or a case-based question again, that seem to mention symptoms like joint pain, fever, fatigue, and rash, these may be all suggestive of an underlying rheumatic disease. Arthralgia without physical findings of arthritis would suggest infection, malignancy, orthopedic conditions, as well as other benign pain syndromes and pain syndromes like fibromyalgia itself. But there's this particular condition which is called growing pains, especially affecting the 3 to 10-year-old children with a history of episodic pain occurring at night after increased daytime physical activity, but is relieved by massage. There will be no other limp or complaints in the morning or other associated symptoms. But once all the imaging studies have turned out to be really normal, and again, the age group is this particular 3 to 10-year-old kids, then yes, you may attribute it to growing pains. Let's look at this question. In a patient with known Kawasaki disease, which phase of the illness gives the highest risk for sudden death? Okay, if you review the phases of Kawasaki disease, which phase would be associated with sudden death? Okay, it's the subacute phase. So let's review again what Kawasaki disease is. The old term of which is mucocutaneous lymph node syndrome. Okay, so there should be fever for at least 5 days. It's remittent, it doesn't go back to normal, and it's not responding to antibiotics, plus any of the 4 following features. So you might want again to remember it as CRASH, okay, C-R-A-S-H. So that's conjunctivitis, rash, adenopathy, strawberry tongue, and H is for hand changes. So when you look at the eyes, okay, you have some form of conjunctivitis, reddish or red conjunctiva without any exudate. Rash could be any form, but it's not vesicular. So the rashes that you will see on the trunk, on the extremities, may be macule, papule, okay, but you will hardly encounter vesicles in Kawasaki disease. A for adenopathy, this is cervical in location, usually single, more than 1.5 centimeter in diameter. S is strawberry tongue, so when you ask them to to open the mouth, examine the oral cavity, you will see red, cracked, swollen lips. And then the papilla of the tongue seems to be protruding, so that resembles that of a strawberry. Hence the term strawberry tongue. And for the hand changes, let me emphasize that during the first week of the illness, the acute phase, you will see the hands, or you will note them to be indurated or swollen. It's not only the hands, but rather also the feet. So there's induration of the hands and the feet, again, during the acute phase. And going into the subacute phase, then the skin on the hands and the feet will start to peel. Okay? So magkakaroon ng pagbabalat surrounding the areas, and that is usually noted beyond the acute phase. So the other features of Kawasaki disease, I'd like to emphasize again that in particular for the less than 1-year-old age group, now 1-year-old and less, the rashes may not be that generalized or noted in the trunk or the extremities, but rather the redness may just appear on the perineum area. In fact, the redness there on the perineal area will also be followed by desquamation, okay, of the skin in that particular area. And when I mentioned earlier that the hands and feet are indurated during the acute phase, it is also noteworthy that when they enter the subacute phase, okay, na 1 to 3 weeks after the onset of illness, there will be desquamation, okay, yung nagbabalat na nga, no? Under the fingers and under the toes, okay, yung balat nila. Take note of extreme irritability, especially in infants. And this is also important. The dreaded coronary artery aneurysms develop usually in the second to third week of illness, especially in untreated, unrecognized Kawasaki disease. Remember that Kawasaki disease is a medium-sized vasculitis. Namamaga yung mga medium-sized vessels, in particular, the left coronary artery would be commonly involved in Kawasaki disease. Okay, so you see here the desquamation, okay, on the toes, okay, and on the fingers. And here, ito yung induration, no, namamaga talaga, no, during the acute phase. So again, the acute febrile phase, it lasts about 1 to 2 weeks, and there's fever and other acute signs of illness. For the subacute phase, it is notable that aside from desquamation, there will be thrombocytosis. In other words, when you get patients beyond 1 week of the illness, most of the parents would bring their kids and tell the doctor, ang tagal na ng lagnat. Beyond 7 days na. We're almost 10 days na. Magto 12 days na po ang lagnat. No? Nag-aalala kami kasi po bitak-bitak yung there's cracked lips, mapula, tsaka para po siyang may sore eyes, all of those. And then may rash po. When you do a CBC during this particular period, it is noted that there is increase in the platelet count. We know that the usual range is 150 to 400,000. So it's not surprising at all to encounter platelet values reaching 600,000, 700,000. I even had patients 1 million platelet. Okay? So nangyayari yun talaga, okay, dahil nga inflammatory marker ang platelet, just like your ESR and CRP. So thrombocytosis is expected during this phase. And again, the development of coronary aneurysms, especially for those untreated again. And the convalescent phase is when all the clinical signs have disappeared and continues until ESR and CRP now start to return to normal. That's about 6 to 8 weeks after the onset. I'd like to mention that there is such a thing as incomplete Kawasaki disease as well as atypical or atypical Kawasaki disease. So what's the difference? Here, for atypical Kawasaki disease, this is any infant or child with 5 or more days of fever, just like the classic Kawasaki disease, with 2 to 3 of the principal clinical features and have compatible laboratory findings. In this subtype or variant of Kawasaki disease, they have manifestations like renal failure, unilateral facial nerve palsy, pulmonary involvement, testicular swelling, acute abdomen, and even hemophagocytic syndrome. You will see that there are other systemic manifestations, other involved organs here. Unlike in incomplete Kawasaki, this is considered in all children with unexplained fever for 5 or more days with 3 or less of the clinical criteria. So, pag case-based question again, hahanapin nyo kung name-mention, kasi diba crash, C-R-A-S-H, hahanapin nyo lang doon kung may na-fulfill siya na 4 or more of the criteria with 5 or more days of high-grade fever. Pero kapag sa incomplete, 3 or less, tapos isa pa, more common in young infants. Ang Kawasaki disease kasi, yung classic the peak age is 1 to 5 years old. Usually, pag nagkakaroon ng Kawasaki disease sa less than 1 year old, the manifestation is incomplete. Kaya mas common ang incomplete Kawasaki disease sa less than 1 year old. Common din ang perennial erythema and desquamation in incomplete Kawasaki disease. And it also makes these infants at a higher risk to develop coronary artery lesions. Okay. So what are our ancillary tests in Kawasaki disease? Again, this is a clinical diagnosis. There is no particular diagnostic test. However, in your baseline CBC, what you will expect is a normal WBC, or sometimes it's elevated, no? But don't be surprised, it can be normal. And then I mentioned earlier that there could be Also thrombocytosis here, rapidly increasing in the second to third week. And then your other inflammatory markers like ESR and CRP, of course, are elevated. And then you may have some form of delusional anemia, so low hemoglobin levels for these patients. You may have sterile pyuria, mildly high liver transaminases. The most important part is when you suspect Kawasaki disease is include in your diagnostics 2D echo. You need an ultrasound of the heart to be performed at diagnosis and repeated after 2 to 3 weeks of the illness. And the guidelines say if both are normal, a repeat study should be done 6 to 8 weeks after the onset of the illness. And in the management of Kawasaki disease, the mainstay would be, of course, IVIG. Okay? Your IVIG supposedly will help bring down the temperature. It helps in the defervescence of the child. So pag na-bring down na yon, okay, that's a good thing, that's a good sign. However, if there is persistent or recrudescent fever 36 hours after completion of the initial IVIG infusion, which is, by the way, 2 grams per kilo IV. Kapag naging persistent pa rin ang fever, then this is what they call IVIG resistant Kawasaki disease. And these patients now are at increased risk for coronary artery aneurysm. What to do? Another dose of IVIG, again at 2 grams per kilo, is given to patients with IVIG resistance. Retreatment of patients with refractory Kawasaki disease. Ibig sabihin, nakaka-2 doses ka na, refractory pa rin, hindi siya responsive. Ang parameter natin yung persistence of the fever. Okay? If there is poor response to the second IVIG, the next call in the algorithm is giving pulse therapy or steroid. Then we use IV methylprednisolone and we give it for 30 days. Only a small patients only with a small solitary aneurysm should continue aspirin indefinitely. And when the pandemic hit us globally, there is a new condition that was termed MIS-C, or multisystem inflammatory syndrome in children. This is a serious, rare condition in children in which the body's own immune system overreacts to a stimulus. I remember that the first 2 countries that described this particular condition was the United States and the United Kingdom. Okay, I think they saw this kind of patient. They encountered this condition basically in England first. So MIS-C results in inflammation of multiple organ systems, leading to impaired organ function and organ failure. It was diagnosed in less than 21 years of age. Still, there is an unknown cause, but there was a mounting evidence linked to COVID-19 infection, okay, to SARS-CoV-2 organism. And as we speak, we still need more research and evidence as to establish its relationship with the SARS-CoV virus, as well as for the proper monitoring of MIS-C. But the criteria set by the Centers for Disease Control in Atlanta, Georgia by 2020 is the following. Patient of 21 years of age or younger who has had a fever of 38 for at least 24 hours, that's 38 Celsius, and then blood work showing indications of inflammation. Again, those are your simple ESR, CRP, okay, procalcitonin, the inflammatory markers. And then it requires treatment at the hospital, often in the ICU due to severe illness, including dysfunction of 2 or more organs, in particular, heart, blood vessels, GI, lungs, kidneys, skin, eyes. Basically, kahit na anong system or organ pwedeng ma-involve, basta 2 or more. And then there's absence of other diagnoses explaining inflammatory symptoms. And of course, the all-important positive test for current or past infection by SARS-CoV-2. Okay? Or failing a positive test, evidence of exposure to someone with the virus within 4 weeks of the onset of MIS-C symptoms. So in other words, MIS-C is talagang linked with a prior or an ongoing SARS-CoV-2 infection. You may COVID din. Furthermore, there is evidence of inflammation, including but not limited to one or more of the following. So, ang maraming sa set of diagnostic tests nakapackage yan, no? So, syempre CSR, ESR, CRP, you have fibrinogen, okay, you have procalcitonin, again produced by cells in response to tissue injury and bacterial infections. Your D-dimer is part of the workup, which is the degradation product of your fibrin, which is a reflection of the ongoing activation of the hemostatic system. Ferritin is one of those inflammatory markers and is a key mediator of immune dysregulation via direct immune suppression and pro-inflammatory effects, which contribute actually to cytokine storm. LDH also as well. You have interleukin-6, neutrophils, elevated ang neutrophils, reduced lymphocytes, low albumin. Okay? Tandaan kasi natin, di ba, binabantayan dati, kung naalala nyo sa may COVID, pag talagang yung severe COVID, pag nag-cytokine storm, di ba, takot na takot ang mga specialists and the intensivists kasi alam nila these serve as molecular messengers and regulate body's response to disease and infection. So kung sky high na yung levels niya, tapos nagde-deteriorate na talaga yung tao, di ba, this has been a precursor or a predictor rather of a poor prognosis, okay, the cytokine storm. Other evaluations, of course, would include baseline readings of your ECG to the echo, troponin, and the B-type natriuretic peptide. Your BNP is released in response to changes in pressure inside the heart. So makikita mo rin kung gaano ang effect niya doon sa cardiovascular system. Now, for MIS-C happening in pediatric age group specifically, again, there are Kawasaki-like features but do not need to fulfill the KD criteria. What is important here is the history of exposure to COVID, recent or past infection man yan, okay, with SARS-CoV-2. So you need to do the RT-PCR, which up to date still remains to be the gold standard for identifying COVID infection. So the difference between severe COVID and MIS-C is that lungs in MIS-C not significantly affected yan. The heart is most commonly affected, okay, sa MIS-C. Okay. So we usually check the heart rate. Significant tachycardia is usually found in cases of MIS-C. Okay. So ang similarity lang niya sa Kawasaki, meron kasi siyang nagfi-fever, 5 days or more, pwede siyang nagra-rashes, pwede siyang cracked lips, but usually symptom-wise, doon na nagsa-stop. Pero dahil extended period yung fever niya, tapos part of the workup of someone who was fever still is having an RT-PCR, that's when we are able to identify and pick up na, ay, COVID yan, hindi na Kawasaki kasi nag-positive siya sa RT-PCR. And then again, kapag 2 or more systems involved na nagde-deteriorate, mukhang MIS-C yun. So that's the spectrum of it. Now we move to juvenile dermatomyositis, one of the rheumatologic problems, which is actually the most common of pediatric inflammatory myopathies. So from the term itself, dermatomyositis, so you will see focal areas of involvement of the muscles together with skin findings, which lead to progressive proximal muscle weakness. Highlights of this condition are presence of Gottron papules. These are alligator skin-like appearance. So when you palpate them, when you touch them, it feels very rough. The skin over the metacarpals and the proximal interphalangeal joints may be hypertrophic and reddish pink and very rough to touch. Another feature is what they call heliotrope eyelids or the rash wherein when you look at the periorbital area, this is a violet, reddish violet skin or discoloration crossing over the bridge of the nose. Pictures. Okay, so here are your Gottron papules. Take note of the usual location of the papules again in the joints. And then here's the heliotrope rash, notably periorbital area. There's another PE finding called the Scholl sign found in dermatomyositis, which is macules na dikit-dikit, very red, extending across the upper back, neck, and shoulders. That's why it's called shawl, because that is where the shawl, when you drape over a shawl, di ba, sa paligid mo, so it supposedly covers the shoulders, upper back, and neck. And these are the locations where the rashes are found. American College of Rheumatology as well as the European Union, no, League for Rheumatology. There's a classification criteria for juvenile idiopathic inflammatory myopathies. So, sa mga dermatomyositis, important kasi sa algorithm of diagnosis is doing a muscle biopsy. But in this 2017 classification criteria, they have a specific column for those patients who did not undergo muscle biopsy and for those patients who underwent muscle biopsy. So here are the parameters for that. The age of onset, usually equal or more than 18 years and more than 40 years old. And then the muscle weakness is there. Of course, if you get the history and observe that there is symmetric weakness or progressive weakness of the proximal upper extremities, the neck flexors being relatively weaker than the neck extensors and in the legs too. And I mentioned earlier the pertinent features of the skin, heliotrope rash, the Gottron papules, and the rash. These are all, they have specific points as to the scoring for whether they are fulfilling the criteria for juvenile idiopathic myopathy. And then you also have dysphagia or esophageal dysmotility. And then for the laboratory measurements, not all institutions have the anti-Jo1. It's the antihistidyl tRNA synthetase autoantibody present. But of course, these are more reliable and more practical criteria to test and to request, such as your serum CK, especially the muscle isoenzyme, or LDH or SGOT, SGPT levels. When they do muscle biopsy of the involved muscles, what they look for are the endomysial infiltration of the mononuclear cells. They look at the myofibers, the perimysium, perivascular infiltration with mononuclear cells, as well as perivascular atrophy and vacuoles, all of which, if present, increases the likelihood that this is juvenile dermatomyositis. Okay? So this is how they would utilize the classification and the scoring system. So equal or more than 7.5 score, then that is definite for inflammatory myopathy such as your dermatomyositis. Probable dermatomyositis is scores of between 5.5 to less than 7.5. And if it's less than 5.5, then it is just possible dermatomyopathy. We also look into the nail fold capillaries, which in this illustration, you will show periangual avascularity. No? Kulang siya ng mga vessels, yung tinatawag na dropout capillaries or dropout avascular area. Again, vessel dilatation with terminal bush formation. So, ito yung isa sa mga pertinent manifestations of dermatomyositis. I mentioned earlier the requesting of your alanine aminotransferases, your CKMM. Another one that is worth mentioning is requesting for antibodies to polymyositis scleroderma. So that's PMSCL. If the institution has this blood level, the antibody level, identifies a small group with the protracted course of the dermatomyositis involving the lungs and the heart. So there's a small subgroup that may be involving lungs and the cardiovascular system. And it is through the antibodies like this that this is identified. So part of the diagnostics, again, aside from imaging, MR, again, I'd like to emphasize muscle biopsy will confirm the diagnosis. For severe cases, we give steroids, that's methylprednisolone, and then experts also add methotrexate to decrease the length of treatment with steroids, and then they may use folic acid to reduce the toxicity and the side effects of folate inhibition, like oral ulcers, the presence of nausea, and anemia. And for severe cases, we add IVIG. Let us look at this next STEM question that is quite long again. So again, I said focus on what is being asked. You are asked to diagnose again this 7-year-old male with a rash extending from the buttocks to the lower extremities. Look at whether it's acute or chronic. So You may say this is acute because this has just been 1 week ago. The rash is described as raised, pink to red, purpuric lesions. So may flu siya before, but right now, there's right knee pain with swelling but not warm to touch. He is febrile with 6 to 8 RBCs, protein plus 2, that's still okay because sa qualitative analysis of urine, presence of protein, trace 1 plus, 2 pluses of protein are still associated with non-pathologic proteinuria. 3 pluses to 4 pluses of protein in the urine is now associated with pathologic proteinuria with or without edema of the patient. Trace plus 1 plus 2, non-pathologic pa. Okay? It may be attributed to fever, exercise, okay, underhydration of fluids. So WBC 0 to 2, that's okay. Glucose is negative, bacteria is plus 1. So if there is a prior history of flu, a viral infection, now having purpuric rashes, look at the location, buttocks to legs. Among the choices, what comes to mind? What is being described here is a very classic description of this condition. If you answered letter B, you are correct. That's HSP, hinoxion line purpura. So this condition now is vasculitis of small vessels. Okay? If you recall, I said Kawasaki disease is vasculitis of medium-sized vessels. So for hinoxion line, it's IgA mediated. Okay? The dermal capillaries and post-capillary venules are affected. And it's the most common cause of non-thrombocytopenic purpura in children. Unknown cause, pero again, no, if you do the history taking, di ba lagi naman tayo nagtatanong, supposedly nagtatanong, sa ROS, sa past medical history, naging ill ba siya other than the present problem now? Meron po ba siyang naging sakit 1 week, 2 weeks ago, 3 weeks ago prior to the consultation? We try to establish that because especially in cases of vasculitis, you will be able to end up picking up this particular clue that there has been indeed a prior viral infection. It usually affects 3 to 10 years old and more predominantly affecting males and is linked with nephritis. They have your major histocompatibility complexes, HLA-B34 and HLA-DRB1. If you recall, the major histocompatibility complexes, these are substances that may be measured in the blood that when present in an individual, identifies that particular individual to have a high propensity or a high possibility to develop such disease. So for HSP, it's the presence of HLA-B34 and DRB1. So if you look at the current picture now, you will see the classic purpura. They are raised in crops. They are palpable. So nakaangat sila, no? And these are heavily concentrated from the buttocks down. Okay? So sa dependent parts. But halos wala, no? Kung meron man, very, very occasional sa trunk, sa back. Pero heavily present from the buttocks down to the thighs, down to the legs and feet. Lab tests are neither specific nor diagnostic. Again, this is a clinical diagnosis together with the other presentations and the other manifestations such as your severe abdominal pain, and then you have arthritis as well. Okay? So this is self-limiting. This is just addressing the symptoms when you manage them. If there is presence of severe abdominal pain and joint pains, then we may give steroids, okay, oral steroids for at least 7 days. Again, no need to taper them because it's short course. And then, regardless of the severity of symptoms, if you do your urinalysis and you see that there is, a little blood in there, hematuria or even proteinuria, then these patients would require serial urinalysis for 6 months after diagnosis, especially those who presented with hypertension. So, ang pinaka-goal dito, titingnan nyo lang dun sa repeat urinalysis niya after 6 months kung nagpe-persist yung RBCs niya. Okay? Then again, HSP, Meron kang purpuric lesions, that's the hallmark feature. And then you have joint pains, you have abdominal pain, and you have renal involvement. Next is this case, a 10-year-old female asking for the diagnosis of this, no? This 10-year-old girl has morning stiffness and joint pains later in the day, particularly in the knees and sometimes in the ankles. That has been bothering her for the past 2 months, so something chronic na rin, no? PE reveals joint swelling with limitation of range of motion of the knees and ankles. No other complaints. If you look at the vital signs for a 10-year-old, definitely this is within normal. The patient is not febrile. So just basing on morning stiffness and joint pains later, I'm sure you have an idea that definitely this is juvenile idiopathic arthritis. But what type of JIA? Okay, so you look at the involved joints. Okay, so if you answered oligoarticular JIA, then you are correct. Okay, 5 joints or more, that's polyarticular. Systemic onset, so you have the involvement of the knees and joints, but from the term itself, systemic, there now is the appearance of fever together with the rash, apart from the arthritis. So that is systemic type of juvenile idiopathic arthritis. Basta may lagnat, may rashes. Oligo versus polyarticular, nagkakatalo yan doon sa number of joints involved. This one, a 13-year-old female naman, again, diagnosis, complaints of fever, rash, and joint pains. 2 months ago, there's pain and swelling over the knees and sometimes the ankles. She has also been having intermittent fever almost every other day, ranging from 38 to 39, and has a faint salmon-colored evanescent rash, especially at the height of the fever. As I said moments ago, if you have seemingly arthritis here on the history, presence of fever, presence of rash, this is how it looks like in systemic onset juvenile idiopathic arthritis. So based again on the International League of Associations for Rheumatology, there's a classification of juvenile idiopathic arthritis. So here sa systemic, no, again, equal or more than one joint involved, preceded by fever for at least 2 weeks in duration, documented to be daily for at least 3 days, accompanied by one or more of the following. As I said, there's rash, there might be generalized lymph node enlargement. Take note of hepatomegaly, splenomegaly, or both. And then serositis, no, yung may mga fluid. Oligo is 1 to 4 joint involvement during the first 6 months of disease. Okay. Polyarthritis is 5 or more joints. Subclassification, it can be polyarthritis, 5 or more joints, rheumatoid factor negative, so this is a blood test, or rheumatoid factor positive involving 5 or more joints. Psoriatic arthritis, from the term itself, you have arthritis, you have psoriasis, which is the silvery scaly lesions, or arthritis and at least 2 of the following. Pag sinabing dactylitis, may swelling of 1 or more digits of the fingers in an asymmetric distribution extending beyond the joint margin. Pag sinabing nail pitting, if you look closely at the nail beds, minimum of 2 pits, yung parang uka-uka sa nail beds, on any 1 or more nails at any time, and onycholysis, yung sisira dito yung sa merong border nung nail. Psoriasis also in first degree relative. Enthesitis-related arthritis, when we say enthesitis, may tenderness at the insertion of a tendon, ligament, joint capsule, or fascia to the bone. Okay, with at least 2 of the following. Meron kang sacroiliac joint tenderness. So that's, ang presentation niyan, lalo na sa adolescent male, ay chronic lower back pain, lumbosacral pain. Yung male na yon, usually positive siya sa HLA-B27 and childhood to adolescent onset, no? In males. You may also have anterior uveitis there. and history of your ankylosing spondylitis, which is again, the history o ankylosing spondylitis mo is the chronic lumbosacral pain in males. Okay? And then you have undifferentiated arthritis. To compare ILAR, okay, yung International League, that's 1997, and the old one, the old classification back in 1977, that's the American College of Rheumatology. Ang pinagkaiba lang naman dyan, guys, yung luma, ang term nila JRA, Juvenile Rheumatoid Arthritis. Ngayon, yung bago, 1997 and up to present, we now call it as JIA. Pareho lang ang minimum duration of onset of symptoms, equal or more than 6 weeks. Age at onset pareho din. Basta less than 16 years old, onset, juvenile idiopathic arthritis. And I already mentioned polyarticular, okay? Oligo na ang tawag sa new classification. Old term ang polyarticular. And then you have polyarticular here, you have systemic, okay? Systemic type of arthritis with fever and rash. So what are the goals for treatment? We want to achieve remission, of course. We want to prevent or halt joint damage and to foster normal growth and development. To have a full life, no, na walang limitation of mobility and in the range of movements. Patients would need, even in adults, they would need individualized treatment plan and tailor the management based on the subtype and severity. We identify the prognostic factors, how they respond to medications, and then of course, yung mga binibigay kasi natin may have potential adverse reactions or toxicities. But let me emphasize that the first line drug of choice for JIA is still NSAIDs. Ito pa rin. So we may give naproxen or ibuprofen or meloxicam for as long as wala silang established NSAID hypersensitivity. And these are the doses for juvenile idiopathic arthritis. You may give it for polyarthritis, oligo, and systemic type of JIA. Just watch out. Gastritis kasi diba NSAID, so dapat on full stomach. Just watch out for renal and hepatic toxicity as well. But, okay, as the disease progresses and if you are having a hard time to control the evolution and the progression of the arthritis, the algorithm would state that we may now use your DMARDs, disease-modifying anti-rheumatic drugs. The oldest of which and the least toxic among the DMARDs is methotrexate, but it involves giving subcutaneous weekly. This is again for systemic type, polyarthritis, and oligoarthritis. For methotrexate, we watch out for nausea, vomiting, oral ulcers, liver toxicity, and blood dyscrasias. There's another DMARDs, a category of DMARDs, and that is sulfasalazine. This is basically useful for polyarthritis. Okay? And you just watch out for GI upset, allergic reactions. Pero kasi sulfa drug, so alam natin na bantayan, we have to monitor for possible severe drug hypersensitivity, and that would be your Stevens-Johnson syndrome. No? Ang mga drugs na notoriously involve in Stevens-Johnson syndrome, the very severe hypersensitivity reaction are your NSAIDs, your sulfa drugs, and your anti-epileptic drugs. These are the top 3 medications that if a patient has hypersensitivity to it, they might go into the severe type wherein there is 2 or more mucocutaneous involvement as a reaction to the drug. So pag sinabing 2 or more, hindi lang yung rashes sa balat, pati mata, nagda-dry eye syndrome, bitak-bitak na yung labi, so meron kang oral mucosa. Sometimes the lungs, meron kang pneumonia, and sometimes in the perineal area, the genital area, nagagasgas, no, yung lining. Okay, I'm talking about 2 or more systems involved in the severe drug hypersensitivity reaction. Again, that's Stevens-Johnson syndrome. Okay, going back, there are other biologic agents now for the treatment of JIA. Another one is anti-tumor necrosis factor. common, the popular drug here is etanercept. This is given subcutaneously. Again, this is for poly, oligoarthritis, and as well as systemic. This could be an immunosuppressant, and there could be lupus-like reaction in the demyelinating disease. Just take note of the possible side effects. There's also canakinumab, which is under interleukin-1 inhibitor classification. Again, given subcutaneously. Very good for systemic type of arthritis. Again, it's an immunosuppressant, so we just watch out for its potential side effects. And tocilizumab, which is interleukin-6 receptor antagonist. This depends on the weights and if given IV or sub-Q. Again, very important. An important choice for systemic and polyarthritis, we give tocilizumab IV, but for polyarthritis, we give tocilizumab subcutaneously. All of these are immunosuppressants and may have liver toxicity. So, just a reminder, the indications of using the newer ones, the DMARDs drugs, if there's failure of methotrexate, remember, methotrexate is still the prototype, yung pinakauna pa rin, no? Those with poor prognostic factors, then the rheumatologists would definitely entertain the use of the newer ones and with severe disease onset. Okay? Early aggressive therapy with methotrexate and etanercept may result in earlier achievement of inactive disease. So that's what we want. For systemic arthritis, steroids are started followed by interleukin-6 antagonist therapy to induce a rapid and dramatic response. Next, we go to SLE, systemic lupus erythematosus. Ang tatandaan nyo dito, this usually affects females, very high preponderance, 5:1, okay, and has a very unpredictable course of illness and usually affects adolescent girls. This is autoantibody production against your self-antigens resulting in inflammatory damage to target organs. They would find fibrinoid deposits in the blood vessel walls of the affected organs. Ang nakakatakot sa SLE, multisystemic din siya, no? Parang Kawasaki, parang mga MIS-C, multisystemic. So, pwedeng namamaga lahat ng vessels, no? Sa lungs, heart, kidneys, joints, muscles. Even hematologic system is affected. You have oral ulcers. You have photosensitivity here, butterfly rash, malar rash dito, no? And also psychiatric involvement and neuro involvement kasi pwedeng may cognitive dysfunction as well as psychosis and seizures. So, currently, there are 3 classification criteria being used. The oldest one, again, and the prototype of everything is the ACR. Remember the 4 out of the 11 criteria. Okay, yung Brain Soap MD. Diba? Yun yung mnemonic for that. It has a sensitivity, that particular old criteria, yung 4 out of the 11. I'll show it in a bit. The use of that criteria has an 82.8% sensitivity and able to say that this is not lupus, which is specificity of 93.4%. There are newer ones. They call it SLIC, Systemic Lupus International Collaborating Clinics, with a high sensitivity at 96.7%. And they also have EULAR, European League Against Rheumatism. Ang tanong, ano bang ginagamit ngayon ng mga examiners? Okay. Ang lagi naming sagot ni Doc Ian De Vera ay usually kung ano yung nakalagay sa Nelson. Kasi yung mga examiners naman yan would heavily rely on the official textbooks of certain clinical subjects. Like in pediatrics, it's still Nelson Textbook of Pediatrics. The thing is, sa Nelson Textbook of Pediatrics, na-mention yung old one. Pero na-mention din yung bago. So, to settle things, the way to go is to familiarize yourself with the old classification as well as with the new one. Makikita nyo rin naman, halimbawa may test question on SLE the way the examiner would construct the case, kung makikita nyo yung words na ginagamit doon, yung words na under ng criteria ng old one, yun yung lumilitaw eh. Kasi, I will show you ha. Ito, like this one, this is the new one. the 2019 ACR classification criteria for SLE. This is the, if you look at it closely, the criteria here mentioned are very similar to the 1997 one. Iba lang yung pagkakastate. Iba lang yung pagkakastate niya. So, sa 2019, the entry criterion is necessary to classify SLE. And that entry criterion is having an ANA level, okay, at a titer of equal or more than 1:80 on human epithelial 2 cells or an equivalent positive test. So, ANA level to, no, na mataas. At least one clinical criterion is required to classify SLE. So, ito yun. Ginawa nating algorithm. So, may anti-nuclear antibodies ka. So, pag nag-positive ka niya, if absent, do not classify as SLE. This is the newer one, ha? If present, we apply the additional or the additive criteria. I'll show you here the additive criteria. Ito yung sa bago, ha? Pero tingnan nyo yung presence ng criteria. Fever, leukopenia, delirium, psychosis, oral ulcers, pericardial or pleural effusion, pericarditis, joint involvement, proteinuria, lahat. Okay? Lahat naman na to ay mentioned din dun sa old one. Ano yung old one? Here. Soap Brain MD. Ito yung alam natin na mnemonic for the 1997 SLE criteria. C. But it's the same. Serositis, oral ulcers, arthritis, photosensitivity, blood changes. R is renal disorder. ANA is the abnormal titer. Immunological changes, neurological signs, the Mahler rash, and the discoid rash. The discoid rash ay hyperkeratotic changes in the cells involving the dermal and epidermal junction. Okay? So all of this, pag tinignan nyo, Soap Brain MD, kapareho lang siya niyan. Etong bago. Okay? Ang kaibahan lang, ginawa dito sa ANA abnormal titer, dun sa bago, siya ang entry level. Kailangan meron daw muna na ANA na level bago mag-identify ng other criteria that can be found in the different organ systems. But the organ systems mentioned here are definitely the same symptoms mentioned in the old classic 1997 criteria. I hope you get that. Okay. In fact, ang discussion pa nga sa Nelson, no? ANA indeed is an excellent screening tool. It's positive in 95 to 99% of patients, though it has a poor specificity for SLE. Okay? What's more specific for lupus, kunyari naghahanap ka ng mataas na specificity kasi mababa ang ANA, you can do anti-double-stranded DNA. This is also a blood test. The value, the result that you get from anti-dsDNA is a reflection whether the disease is active or not. Kung masyadong mataas, alam mong kasalukuyang active at talagang yung mga manifestations niya, no, parang galit na galit, lahat na inflamed, no, lahat sa multi-organ involvement. You have low total hemolytic complement, C3 and C4 in active disease. And this one, the last bullet, anti-Smith antibody is found only in SLE, making it also specific for the diagnosis of SLE. So you have several diagnostic tests that are actually useful. Entry level mo lang yung ANA, but if you want to determine, is the disease right now, is it active or not? That's your anti-double-stranded DNA. I am confused because there are other rheumatologic and vascular conditions that are also positive with ANA, which is true. I want to be more specific. Do your anti-Smith antibody. So that's how you use that. This is lifted again from Nelson Textbook of Pediatrics. So you will start definitely with your the first one again is, you know, for lupus, you may do your intramuscular, your antiplatelets, anticoagulants here, okay? And then you have your hydroxychloroquine here. But as the disease progresses again, if it becomes moderate to severe, then you have the addition of methotrexate, okay? Then you may have other, the newer ones, the new adjunct therapy for SLE. But the thing is, we still start the patient on steroids. And this is the review for common pediatric rheumatologic cases. Next to review is pediatric cardiology. Of course, the most common condition or complaint, rather, that would be presenting if you are dealing with the cardiovascular system is the presence of a murmur. Sometimes you hear it as an incidental finding, and sometimes it is right there during your physical examination. So the approach to this is definitely to identify the timing. When are you hearing the murmur? Is it during systole or during diastole? Or is it continuous, machinery-like murmur with no distinction between the first and the second heart sound? What about the grading of the murmur? The way to grade murmurs in pediatric patients is the same with that of adults. And then, of course, what are the associated symptoms? Has there been repeated or recurrent pulmonary infections which are expected from having an untreated or unrecognized congenital heart diseases? Are there any cyanosis, bluish discoloration, and clubbing of the nail beds? Is there history of syncope, okay, palpitations, fatigability, okay, dyspnea, orthopnea? Okay? So eventually you have to identify and elicit all of these possible associated symptoms. As I said, the grading here is like that of adults, which means that when you use grade 4, already there is a thrill. Okay? So the way to remember this is after 3, there is a thrill. Okay? Kasi yun ang difference no? Sa mga, may tinatawag tayong innocent or functional heart murmurs. Pag mga innocent or functional murmurs, yes, there is a murmur, but they hardly go over grade 3. The loudness and the intensity that you will hear is up to grade 3. Whenever there is a thrill, the thrill is you palpate it, you feel it. These are parang sensations, vibratory sensations that you feel on the palm of your finger as you put the finger on top of the precordium. So if it is very loud, and then there are vibratory sensations there, that's a thrill, and most probably it really is a pathologic murmur. Okay? And of course, the louder it becomes, then you assign grade 5 and even grade 6. Some few points, quick key features, developments during morphogenesis of the cardiovascular system. The early presomite embryo, the first identifiable cardiac precursors are angiogenetic cell clusters arranged on both sides of the embryo's central axis. And there is note and observation of formation of cardiac tubes. The paired cardiac tubes are already there, apparently, by 18 days of gestation. Actually, hindi mo pa alam na buntis ka. Okay? Diba yung organogenesis kasi talaga first 3 months of life. Then, these paired cardiac tubes will now fuse in the midline on the ventral surface of the embryo to form now the primitive heart tube. So you now have a primitive heart tube by 22 days old. 3 weeks na buntis. Again, minsan, most of the time, di mo pa alam na buntis ka ng 3 weeks old. What else would happen? So, mag-e-exhibit na ng cardiac cycle yan, 20 to 22 days old. No? And then, yung paghati from left to right ventricle, that happens in 25 days. And then, yung paghati ng left to right atrium, that's 30 days old. And then, at 3 months, the atrioventricular valve and the semilunar valve formation is complete. Going back to identification of murmurs, I just want to focus on this because this is essential in appreciating the overall pathology behind common congenital and acquired heart problems. So, again, for the timing, are you hearing it during systole? There are 2 types of murmurs during systole. One is ejection murmur, the other is regurgitant murmur. Ejection murmur, usually, you hear that between the second heart sound and the onset of murmur. So if you try to analyze ejection, okay, meaning the flow of blood is going through stenotic or deformed semilunar valves. In other words, masikip, narrowed yung valves mo. So paglabas ng dugo, para siyang tinutulak, nag-eject. So, psh, psh. This is also known as systolic blowing murmur or systolic ejection murmur. And you hear this loudest at the second left ICS, nandito sa taas. That's your systolic ejection murmur. To compare with systolic regurgitant murmur, this begins with S1, first heart sound. Due to flow of blood from a chamber that is at a higher pressure throughout systole than the receiving chamber. In other words, meron siyang backflow. Nagre-regurgitate backflow. Nandun na, let's say, nandun na sa may left ventricle, halimbawa may regurgitation, kunyari merong mitral valve regurgitation. Anatomically, you know that that is the valve guarding the blood flow from left atrium to left ventricle. Kung merong kang mitral valve regurgitation, mas mataas ang pressure doon, so nahihila siya pabalik. Regurgitant or turbulent yung airflow. So pagbalik niya, doon nakikreate yung regurgitant sound. And this is loudest at the left lower sternal border. So again, systolic ejection murmur, pinakamalakas sa second left ICS. Systolic regurgitant murmur, heard best at the left lower sternal border. And of course, classic examples would be from the term itself, mitral regurgitation, tricuspid regurgitation, as well as ventricular septal defect. The second timing, is it diastolic in timing, meaning occurring between the second heart sound and the S1? Okay. Ang tatandaan nyo, basta diastolic ang timing, always pathologic ang murmur. So this is a diagram, again, to at least jumpstart or make you recall the locations, no, of the heart sounds that you will hear, no, from the aortic area, here the pulmonic valve, this is the mitral area kung saan mo maririnig yung systolic regurgitant murmur, yung systolic ejection murmur nandito sa may pulmonic area, and you have here the tricuspid area. I mentioned earlier that there is such a thing as innocent or functional heart murmurs. Again, I'd like to mention that the grading of the murmurs of innocent, the maximum is just grade 3/6. Mas malakas pa doon, grade 4, may thrill na yon, pathologic na yon. Isa pa, pag innocent heart murmurs, ang tendency na a-affect niya infants up to young children. Magpa-x-ray ka, magpa-2D echo ka, normal. So that is innocent heart murmurs. What are the conditions that bring about the innocent heart murmur? Think of very extreme physical activities, okay? Mga high output situations, high output cardiac illness. So, yung mga very intense physical activities, severe anemia, high grade fever, may have temporary innocent or functional heart murmurs. The quality of the sound there is more of musical and twang, parang twang siya. So again, I'd like to emphasize, even if you do a basic chest X-ray and ECG, they will all turn out to be normal, which is good. Okay. Pathologic murmur, again, diastolic yan. Pag continuous machinery-like murmur, you all know that as patent ductus arteriosus, that's pathologic murmur. Thrills present on examination, again, grade 4, and additional cardiac abnormalities. All of these are pathologic murmurs. Okay? So, a quick review of congenital heart problems divided into acyanotic and cyanotic heart diseases. Dito muna tayo sa acyanotic heart disease, meaning the direction of the blood flow is coming from the left side of the heart to the right. What blood is on the left side? Oxygenated blood. Pupunta siya sa right side. Kung oxygenated, yung humalo sa right side, siya ay acyanotic ang lalabas. Okay? Kasi oxygenated part yung naghahalo. The common conditions under this classification are, of course, the most common among all congenital heart problems, VSD. Then you also have atrial septal defect. you have patent ductus arteriosus, and then you may have coarctation of the aorta, and then the endocardial cushion defect. Endocardial cushion defect or atrioventricular valve malformation, yung AV valve disease, yan ang pinaka-common, this one, the last one, the most common congenital heart problem associated with Down syndrome. Okay, trisomy 21. Mamaya na natin puntahan tong cyanotic heart problems. Okay? A quick review of VSD. As I said, this is under as cyanotic heart disease from left to right shunt or direction. Okay? So, so there's a hole. There's a hole between the left ventricle and the right ventricle, no? Ventricular septal defect. May butas to. So, the deoxygenated blood finally passed the right side of the heart. It was oxygenated on the lungs, re-entered, now oxygenated blood, re-entered the left side of the heart. Some of the blood that is already oxygenated, some may enter the right side because of the butas here. But if this is normal, all of the oxygenated blood would have exited through the aorta to be distributed around the body, right? But since there's a hole there, so now it depends on the size. Ilang millimeters yung butas nito. Yun yung dami nung papasok dito. Again, okay, sa ganitong situation, there would be increase in the volume overwork. Bakit? The shunt or the transfer of blood occurs mainly during systole, during contraction, when the RV also contracts. So pagpasok ng dugo dito, sabay contract ng RV, the shunted blood, di ba humalo siya, goes directly to the pulmonary artery rather than remain in the RV. Once it re-enters the pulmonary artery, it is now added blood volume and added volume to be circulated in the lungs and will now re-enter the left side. So dahil mas marami na siyang dinadalang volume ng blood, your left side of the heart in VSD will work further and more, it will require extra work. Hence, there will be hypertrophy of the left side of the heart. In other words, expect LVH in VSD. Hypertrophy is seen in ECG. Enlargement of the ventricle is appreciated in the chest X-ray. So nakidaan lang yung blood, sumuot dito, dagdag siya sa blood na coming from the right side, na-oxygenate sa lungs, pasok uli dito, mas marami na siyang hinahandle, mas lalaki yung LV. Left-sided enlargement in VSD. The problem is when patients with VSD has an, let's say, untreated o kaya lost to follow-up o kaya poor compliance to meds. Imagine all those conditions, possible situations wherein there is no continuity of the medications for your VSD. What will happen? Diba may left to right shunt siya. So there's increased pulmonary blood flow kasi nga coming yung extra blood from the RV tinapon sa PA. Diba? Nagkakaroon siya ng shear stress in circumferential stretch. Nadadagdagan yung blood volume na dinadala sa lungs. So there would be endothelial dysfunction and vascular remodeling. So what happens microscopically is that smooth cell muscle proliferation, increase in the matrix, and there could be thrombosis. So magi-increase ngayon ang pulmonary vascular resistance mo. Eventually, chronically, there would be reversal of the shunt, initially left to right, now becoming right to left. Therefore, there might be cyanosis this time. Kasi na-reverse yung shunt mo. So, yung blood coming from the right side, deoxygenated ba? Siya naman yung hahalo sa left side. Clinically, there will be cyanosis. You call this event Eisenmenger syndrome. This is a consequence of untreated, poorly controlled ventricular septal defect. Initially left to right shunt VSD. With all of these changes, hindi nagagamot, poor compliance to meds, whatever reason, nag-cyanosis, nag-reversal, Eisenmenger ang tawag. Okay. The other common cyanotic heart diseases that I mentioned was ASD. Ang kaibahan niya sa VSD, well, number one, the shunt is between the left atrium and the right atrium. So again, yung volume ng blood coming from the lungs will re-enter the right atrium, and this time it is the right side of the heart that will enlarge. So in ASD, you expect more of right-sided enlargement. With VSD, it is more of left-sided enlargement but may become biventricular again, developing into Eisenmenger syndrome. The heart sounds that you hear in atrial septal defect, kasi nasa bandang taas siya di ba? Left atrium, so anatomically, mas naririnig mo, di ba ang sabi natin, pag ejection type of murmur, nasa taas siya, meaning nasa second left ICS. So it's systolic in timing but the character is ejection or blowing. There's also a widely split second heart sound. Whereas in VSD, okay, since again, if you look at the structure, you're dealing with hole between left and right ventricle. So nasa baba. So loudest ang systolic murmur, which is regurgitant in nature, at the left lower sternal border. Sa taas ASD, sa baba VSD. Okay? In time, again, when this is uncorrected, there will be pulmonary hypertension because of the increased blood volume there. And clinically, pulmonary hypertension is heard through the stethoscope by having a single loud second heart sound. And the other cyanotic heart disease is PDA. You all know this as having continuous or machinery-like murmur. Ito ay nasa second left infraclavicular area. So come to think of it, among the cyanotic heart diseases, no, the common ones, ang nasa taas, ASD, but this is systolic ejection murmur. During systole lang. Another murmur na nasa taas, second left area, PDA. But this is not systolic because this is continuous. So tuloy-tuloy yung sound niya. Brrrr. Machinery-like So walang difference or distinction between S1 and S2. So for PDA, you have bounding pulses, wide pulse pressure, left-sided enlargement, and an enlarged aorta. Can you answer this table before we review cyanotic heart problems? If there is cyanosis manifesting within few hours at birth or within few days of life, okay? So ano yung pinaka-common na cyanotic heart problem manifesting at birth? If you answered TGA, you are correct. Transposition of the great arteries. What about cyanosis manifesting after the first year of life, usually during infancy or a toddler? Kapag infant tsaka toddler, most common, you are correct. Tetralogy of Fallot. Okay. So, a quick review. Let's now move on to cyanotic congenital heart problems. Two mechanisms. Either you are dealing with decreased pulmonary blood flow or increased pulmonary blood flow. Doon muna tayo sa first problem. Decreased pulmonary blood flow. Bakit konti lang yung nagpupunta sa lungs, decreased flow? Number one, because there is obstruction. Saan ang pagbabara? Sa level ng tricuspid valve. Okay, baka merong pagbabara or humaharang sa may right ventricular level or the pulmonic valve level. So may pagbabara. Okay? So the direction of the blood here is from right side, deoxygenated ba yun, going to the left. That will enter the systemic circulation. Classic examples of cyanotic heart problem with a decreased pulmonary blood flow are tricuspid atresia, tetralogy of Fallot, and single ventricle. From the term itself, tricuspid atresia did not develop ang alin, tricuspid valve. Nasaan ang tricuspid valve? Between the RA and the RV. So sa tingin nyo, saan pupunta yung dugo from RA to RV kung hindi develop ang tricuspid valve? Itong mga problema na to like tricuspid atresia, there is usually a concomitant or a simultaneous shunt. Usually yung iba may VSD to allow temporary mixing of the blood. Otherwise, walang pupuntahan yung blood. Talagang hindi sila compatible with life. Okay? So the degree of cyanosis depends on the degree of obstruction to the pulmonary blood flow. So, I'll highlight also tetralogy of Fallot. Again, the most common cyanotic heart defect beyond infancy. Okay, so there are 4 features from the prefix tetra. Okay, so you have a large ventricular septal defect, you have RVOT obstruction, you have RVH, and overriding of the aorta. Your RVOT obstruction from the term right ventricular outflow tract obstruction. Okay, so kung halimbawa ito yung heart, sorry ha, napaka-crude. So RA, RV, LA, LV. Diba yung dugo pumunta dito? Bago sila pumunta ng lungs, yung right ventricular dadaan dito ng, diba, pulmonic valve yan. So pag sinabing right outflow tract obstruction, palabas ka ng RV, papunta ka sana ng lungs, yung outflow tract, that is your pulmonic valve, is obstructed. In other words, right outflow tract obstruction is synonymous with pulmonic stenosis. Okay? In other words, yung pulmonic valve mo, okay, etong pulmonic valve mo, this one, is obstructed. Narrowed siya. So, kung narrowed siya, hindi basta-basta magko-congest sa lungs pag may tetralogy of Fallot ka dahil dun sa presence ng PS mo or pulmonic stenosis. What do you hear with in patients with TOF? Meron kang pulmonic stenosis, tas meron kang ventricular septal defect na features, right? Na part of the 4 features. So for pulmonic stenosis, classically you will hear grade 3 to 5 over 6 systolic ejection murmur at the mid and upper left sternal border radiating to the upper back. That is the murmur from your pulmonic stenosis. Again, here, pulmonic stenosis. So stenotic yung pulmonary valve area mo. So pag stenotic, di ba, sabi natin blowing o ejection murmur. So that is heard best again at the mid to upper left sternal border. Dito naririnig usually ang pulmonic stenosis. Nandito sa second or upper border. Okay? With regards to findings in the chest x-ray, of course, you expect decreased pulmonary vascular markings. Ito, hindi masyadong identified yung mga hilar vessels. But what is very notable here is the boot-shaped heart, or in French, cœur en sabot. This is showing the upturned apex. Diba? Para siyang nakaturo sa taas. The upturned apex. Remember, the left ventricle forms the apex of the heart. So this is the left ventricle here that is pointed upwards and now shaped like a boot na naka-side view. Ito yung kumbaga yung leg. Ito yung paa, yung distal leg. Ito, distal leg. Ito yung paa, side view sa'yo, nakaturo, boot-shaped heart. TOF. TOF patients, especially when not yet undergoing definitive treatment or surgery, they might go into hypoxic spell. In Nelson, this is also mentioned as a hypercyanotic paroxysmal attack. Ang haba, no? Hypoxic spell na nga lang ulit. Okay? Hypercyanotic paroxysmal attack or hypoxic spell. Okay. So, ano nangyayari? So, any activity that increases your systemic vascular resistance, like, halimbawa, iyak ng iyak, inconsolable crying, nagtatantrum yung toddler na may TOF, o kaya history of constipation, so magsistrain, yung mga increased Valsalva maneuvers, yung mga defecation, lahat yan pwedeng precursor for worsening of your cyanosis. lalo lang i-increase ang obstruction, magsaspasa, magtachycardia, and again, mag-worsen yung cyanosis nila, leading to hypoxia. Hypoxic na nga kasi to start with. Tandaan nyo ang mga baseline O2 saturation reading ng mga cyanotic heart problems. Mababa talaga. Don't expect 95% kasi cyanotic sila. So baka minsan ang baseline nila 80, 85%. Okay? So lalong nagwo-worsen yon, magiging acidotic sila, tas retention of PCO2. So nag-hyperventilate sila. So sila yung mga dinadala sa ER, susugod sila, dok, nahihirapang huminga. By inspection, ang congenital cyanotic heart disease, kitang-kita mo agad na cyanotic sila. Tapos ang nail beds nila, 'di ba? May clubbing. So alam mo na talaga na may sakit sa puso. Tapos i-verify mo lang. Dati na po siyang na-diagnose, may sakit sa puso. Yung natatarang ng nanay, opo, dati na po may sakit sa puso. Hindi pa ho napapa-operahan. Wala pa po kaming pera. Yung mga stories na gano'n, no? Tapos ang i-address mo doon yung difficulty of breathing nila. Okay? Kasi nag-hypoxic spell sila. Yung iba nahihimatay. Okay? So what do we do with that? First things first, put the child in a knee chest position. When you do this, you trap the systemic venous blood in the legs, you decrease the systemic venous return, and help calm the baby. Next is to also try to abolish the hyperpnea kasi mabilis huminga tas malalim, no, with effort. So to suppress the respiratory center and stop the hyperpnea, we also give morphine. The problem is, tandaan nyo di ba halos mahimatay na tong mga babing to mga toddlers, talagang deepening, worsening of the already present cyanosis. Tapos mag-IV ka pa kasi gusto mong magbigay ng morphine. Huwag ka muna mag-IV kasi struggle is real kapag ganun. Hirap ng huminga, nagtatantrums, halos mahimatay. Instead of IV morphine, acceptable route is sub-Q para lang kumalma. 0.2 times the weight. So halimbawa lang, 10 kilos, 1-year-old na TOF. Times 0.2, 2 milligrams. Sub-Q, mabilis lang. Pag na-stabilize mo na siya, okay, kasi pathophysiologically, nagwo-worsen din, di ba, nag-acidosis. Eventually, you have to correct the acidosis. So, pag medyo mas okay na siya, we establish a peripheral line, we correct the acidosis by giving your sodium bicarbonate very, very slowly, 1 mg per kilo. Halimbawa, 10 kilos. Favorite ko yung 10 kasi madaling i-multiply. Okay. 10 kilos, 1-year-old. 10 times 1 mg, 10. Okay. Kailangan i-dilute with equal parts of distilled water. So, 10 mg of sodium bicarbonate plus 10 parts water. Okay. Slow IV push yun. Oxygen, yes, you may give. It may improve your arterial oxygen saturation, but as I said earlier, don't put too much hope on the effect of oxygen. Tandaan, cyanotic sila talaga to start with. TOF yan eh. So kung ang baseline O2 sat nila ay 80, ay wag kayo mag-expect na magna 95 ang O2 sat niyan. So support lang yung oxygen natin for these cases. This is the knee to chest position. Madaling gawin sa baby. Para lang silang lumpia, no? Ididikit mo lang talaga, no? Knee to chest position. Yung older children, alam nyo, they are aware that such position gives them comfort and relief. Sila na mismo ang umuupo. Okay? Tapos look, no? Talagang clubbed nail beds, no? Sa fingers at saka sa toes. O, sila mismo ang umuupo. Other parameters or other treatment modalities. Kasi talaga ang unang-una dyan, knee chest position, tas pakalmahin, morphine, tapos oxygenation, tas correct the acidosis. Halimbawa lang, sa algorithm, hindi sila na pacify or kumalma dun sa knee chest position at saka sa pagbigay ng morphine. The other alternatives would be starting vasoconstrictors like epinephrine to raise your systemic vascular resistance. Or lang yan hindi sabay-sabay. Or propranolol to stabilize vascular reactivity of the systemic arteries, again preventing a sudden decrease in the SVR. Or ketamine. Okay? To increase also systemic vascular resistance. Yung ketamine, ingat tayo kasi di ba may dissociation sila. So, minsan parang yung mga batang na bigyan namin ng ketamine before, no, medyo may dissociation, nawawala sa sarili. But then again, this is dose dependent din. So for as long as nag-respond naman sila, no, nawawala din yung ganong dissociation nila. I mentioned earlier tricuspid atresia, no. Sabi ko nga, this one, no, can you look at the normal structure first? Okay, so this is your tricuspid valve. So as I said, if you have a tricuspid valve that did not develop atretic, so walang pupuntahan, so magiging underdevelop ang RV mo. Kasi walang dumadaloy na dugo. So again, dapat meron siyang VSD here or an ASD, again, to allow temporary mixing of the blood. You will hear there in tricuspid atresia a systolic regurgitant murmur. This is, sinabi natin, pag regurgitant murmur, nasa left lower sternal border. Okay? Again, this is TOF, boot-shaped heart, and this is the heart sound again. And these are the procedures for definitive surgery kasi talaga sila. The second mechanism is, baka naman yung cyanotic congenital heart problem is due to increased pulmonary blood flow. Wala kang obstruction, pero ang meron sa'yo, abnormal ventricular arterial connections or total mixing of systemic venous and pulmonary venous blood within the heart. Common examples are transposition of the great arteries or vessels. You have total anomalous pulmonary venous return, that's TAPVR, or truncus arteriosus. Yung transposition of the great arteries, again, this is the normal one. First, you look at where the pulmonary artery comes from the RV, aorta comes from LV. So, transposition, nagkapalit. Yung aorta comes from RV, kay pulmonary artery comes from LV. What happens? Diba, may kanya-kanya silang buhay. Wala silang pakialaman. Complete separation of pulmonary and systemic circulation. What happens is that hypoxemic blood circulates throughout the body. The hyperoxemic blood is the one circulating in the pulmonary circuit. Do you think this is compatible with life? Definitely not. Nade-detect nga ito as early as newborn period. Okay, the most common cyanotic congenital heart problem during birth, at birth, no? TGA. So again, mangangailangan sila ng at least ASD or VSD or PDA. Balikan ko lang yung structure. Diba? To allow temporary mixing. Kasi dito, may complete separation siya ng circulation. So, at least kung may VSD ka, may temporary mixing. Kung between LA and RA, may ASD. Or kung may PDA ka, persistent yung ductus arteriosus mo. The ductus arteriosus actually is the connection between the descending aorta, okay, and the pulmonary artery. So, kung nandito pa rin yung ductus arteriosus mo, well and good, again, that is a temporary mixing of circulations. They are needed for survival until the time na ma-schedule yung batang may TGA for corrective surgery. But other than that, sabi sa literature, kapag hindi siya na-correct, hardly na makakasurvive sila beyond 6 months old. Okay? So, there is no heart murmur that you will hear in TGA, lalo na kung intact ang ventricular septum mo. Halimbawa, hindi naman VSD yun, wala silang concomitant VSD. So, intact yung septum mo, wala kayong maririnig na murmur talaga. Very notable lang is the severe arterial hypoxemia. Hypoxemia that is unresponsive to oxygen inhalation with or without acidosis. So, how do you see them in X-ray? How do they appear in X-ray? This is what they call egg shape. Do you see the egg shape there? Mukha ba siyang egg? Mukha nga, no? Hard-boiled egg. Alam mo naman yung mga colleagues natin sa radio, they see things that we don't see. Sometimes meron silang ibang kapangyarihan na ganun, no? Magaling sila, nakakabasa sila ng mga kakaiba sa X-ray. Okay? So, egg-shaped heart, TGA, TGA, egg. Ang layo, ano? Pinipilit ko lang actually. Egg-shaped TGA. So, yung iba pang common congenital heart problem, so ito yung naka-table, no? Na increased pulmonary blood flow. Meron tayong truncus arteriosus tsaka TAPVR. Ito yung mga heart sounds nila. I hope this table helps. Sa TAPVR, ang nangyayari, again, if you look at the illustration, This is the one on the right side is the abnormal one. So all four pulmonary veins, they all drain to the RA. What happens again is, of course, RV volume overload. So malaki ito, lumalaki ang right side. Then there's total mixing of your systemic venous and the pulmonary venous blood within the heart. The most prevalent na type, okay, is a infracardiac group. No? Ito yung merong severe cyanosis and respiratory distress during the neonatal period. The site of connection o yung significantly may obstruction talaga is the infracardiac, as I said, and this is type 3. Baka lang matanong, isa sa mga recall questions, no? Type 3 infracardiac group sa TAPVR. In the chest x-ray, this is what they will see. This is described as here, di ba malaki yung puso, okay, atrial, and then the ventricular side. Snowman, mukha ba siyang snowman? Ayan, snowman, or in some textbooks, figure of 8. Diba? Para siyang number 8. Figure of 8 or snowman sign seen in TAPVR, meaning there is prominent pulmonary artery and the right ventricle. This table is a summary of the congenital obstructive heart diseases. May obstruction naman. So from the term itself, obstruction, ang problema dito, mga stenotic o kaya nakakink. Either yung vessel mo nakakink, which is coarctation of the aorta, or stenotic. Ibig sabihin na stenotic, again, narrowed ang valve. Pinaka-common na pulmonic valve stenosis or aortic valve stenosis. So, ang coarctation of the aorta, ang tatandaan nyo dyan, guys, ito yung description na weak or absent femoral pulses. Mas mataas ang BP sa arms compared sa legs. Tapos sa x-ray, may rib notching or inverted tree sign. Rib notching or inverted tree sign. What they hear here is systolic murmur at the 3rd to 4th left ICS with radiation to the left infrascapular area. For pulmonic stenosis, again, the pulmonic valve, nasan siya banda? Nandun siya sa left upper side. So the way to remember is pulmonic L left upper sternal border. Ang sabi natin, pag nasa taas, systolic ejection murmur. The difference between the murmur that you hear in ASD, if you remember, sa atrial septal defect, systolic ejection di siya. Pero ang murmur ng ASD, walang radiation. Ang murmur ng pulmonic valve stenosis, nagra-radiate sa upper back, sa tapat, sa upper back. So bring your stethoscope there, nagra-radiate, naririnig nyo hanggang doon. Halimbawa naman, ang stenotic or narrowed valve is the aortic valve. Okay? So meron kang systolic ejection murmur saan? Aortic R. Right side naman siya. So nasa right upper sternal border, also radiating to the neck, okay, or to the back. Okay? So these three are the top common obstructive disorders in pediatric patients. So a quick review. Ano nga to? This is a boot-shaped heart. So, okay, you're correct, TOF. This one, okay, anong tawag dito? Ito yung figure of 8 or snowman sign. Yes, this is associated with total anomalous pulmonary venous return. Ito, egg-shaped or egg on a string. TGA, correct. This one, ang tinuturo dito ay yung rib notching. Okay? Inverted tree, inverted E, or rib notching. All are findings in coarctation of the aorta. Okay. Kayang-kaya na itong sagutin. Okay. Egg on a string or egg on its side. Snowman or figure of 8, parehong TAPVR. Rib notching, inverted E or 3 sign. These are all coarctation. Okay. Let's move on to identification of rheumatic fever. It is required that there should be evidence of recent strep infection. So, your strep infection, we're talking about a past or a previous throat infection secondary to group A beta hemolytic strep, which means you may do your ASO titer or your throat swab culture to identify group A beta hemolytic strep. If you're thinking that the rheumatic fever was secondary to strep infection of the skin, the best marker would be kung galing sa skin, yung mga tinatawag nating impetigo. The best marker would be anti-DNase B. So to review, your major criteria is yung mnemonic na Jones mismo, no? Jones, or J for joints, that's polyarthritis. O's for carditis, you have nodule, subcutaneous, erythema marginatum, and S for Sydenham chorea. The minor criteria are fever, if you have a risk factor for that, arthralgia, so pag pain, minor. Kapag swelling, limitation of movements of joints, arthritis, mas importante yon, major yon. Going back to minor, prolonged PR interval on ECG and elevated ESR and CRP. Okay, so yung arthritis nyo, this involves large joints simultaneously or in succession which responds dramatically to aspirin. Paano masasabi na, may carditis yan? Okay? So if there is tachycardia which is out of proportion to the fever, if there is heart murmur, if there is pericarditis, that would be you have friction rub, you have pericardial effusion, chest pain or ECG changes. These are all pericarditis, no? Or big heart seen on chest x-ray, cardiomegyon, or signs of congestion. Any of these or all of this fulfills the criteria, may carditis yung pasyente. Erythema marginatum, non-pruritic, annular, bilog-bilog, like this one. Red, evanescent rash. Evanescent means nawawala, okay, or bumabalik within the 24-hour period. Most prominent on the trunk and the inner proximal portions of the extremities, okay, but never on the face. Subcutaneous nodules, particularly seen kapag recurrent aromatic fever. These are hard, painless, freely movable swellings that you find on the extensor surfaces. So, nandito siya sa extensor surface, ng large and small joints, sa scalp, even along the spine. Nandito siya sa mga gilid-gilid, sa extensors. And last, for the major criterion is chorea, more often found in prepubertal girls. When you say chorea, which is a movement disorder, they will be described as having spontaneous purposeless movements followed by motor weakness. Minor manifestations again are this: arthralgia, fever, CRP, and ESR that are prolonged and that are high. And then when you count, you look at the long lead 2 of ECG. You count the number of small squares from point P to R. One small square is 0.04 seconds. Times 5 is 0.20. Pag lumagpas siya ng 5 small squares, which is more than 0.20. Okay? Pag lumagpas na siya ng 5 small squares, that is already prolonged PR interval, a minor Jones criterion for rheumatic fever. As we said, dapat may evidence talaga ng previous group A strep infection. The most universal one that we use is ASO. Ang maganda dito, the titers are elevated 2 weeks after the strep infection, peaks at 4 to 6 weeks, and decreases after another 2 weeks. So very good yan to include in our diagnostics. Kung hindi man, group A beta hemolytic strep na throat swab culture. Now, how to use the Jones criteria? Kapag may na-fulfill na 2 major manifestations or 1 major plus 2 minor, tapos meron kang evidence of previous strep infection, kunyari positive ASO ka, pasok. Pasok na yan sa rheumatic fever. So, here's a complete set of preliminary diagnostics. At least may CBC ka, your markers, as I said, throat swab culture or ASO titer, your chest x-ray, ECG, and 2D echo. This is basically what you will request in patients whom you suspect to have RF. Ang sinasabi sa March 2015 revised Jones criteria is the use of 2D echo with Doppler. Okay? Yung may color, no? Color Doppler echo. Should be performed in all cases of confirmed and suspected acute rheumatic fever. How to manage? We want to eradicate, of course, the strep. These are the basic ones that we use. PenVK, look at the doses, that's for 10 days. This is oral. Or benzathine, penicillin, 1 IM injection. Or kung may allergy, erythromycin, okay, for 10 days. So part of the management of rheumatic fever, kasi nga 'di ba namamaga yung mga joints. Okay? So tas may carditis pa. Okay? So aspirin would be part of this management at 100 milligrams per kilo per day divided into 4 to 6 doses, especially for arthritis and carditis. Tandaan natin ang carditis pag meron kang tachycardia, may murmur, may effusion. Okay? Prednisone would be considered to be added for carditis and cardiomegaly, or definitely kung may congestion na. And then we taper that after 2 to 3 weeks. Now, we need to prevent RF. So prophylaxis, no, prevention. If it is the first time, no, the first episode, treat nyo agad yung streptococcal throat infection. Ito yung mga ginagamit. Ito. You want to eradicate, you want to treat, ito yon. Oral PenVK, or benzathine penicillin IM injection, or erythromycin. Secondary prophylaxis, you want to prevent the recurrence of RF. Okay, nagka-RF na siya, pero ayaw mo nang maulit-ulit pa yon. Then, pasok siya sa secondary prophylaxis. Two choices again, PenVK, 250 milligrams per orem, or i-injectionan nyo siya standard dose of 1.2 million units deep IM, usually in the buttocks, or kung hindi sa buttocks, sa anterolateral part of the thigh. Sa gilid, anterolateral aspect of the thigh. Every 21 days. I'd like to emphasize this, and I hope you also reinforce this to the parents. Baka malito sila. Hindi ito every 21st of the month. Hindi ito sweldo. Ito ay every 21 days. Example, June 1. Plus 21, June 22. Plus 21, July something. Ay, hindi ko na mabilang. Okay? The point is, iba-iba siya ng petsa. Every 21 days. Yun ang recommendation talaga. Okay? That is for secondary prophylaxis of rheumatic fever. Okay? What's your answer to this? 13-year-old girl, fever and joint pains. 38.8 ang temp. Right knee swelling, warm to touch, very painful. Okay. With holosystolic regurgitant murmur at the apex. So that's the left lower sternal border, radiating to the axilla. Pag meron kang involvement na ng joints, limitation of movement, nagfi-fever with the murmur, syempre ang maiisip nyo na ay, kasi with the murmur so most likely rheumatic heart disease na siya. Okay? Kasi may murmur na siya. Okay? So here are the important points, kasi kung meron na siyang rheumatic heart disease, imagine nyo the involved valves. Most commonly, mitral and aortic valve. Less common na yung pulmonic valve, and hardly na na-affect ang tricuspid valve sa rheumatic heart disease. Okay, going back. Mitral valve could be either presenting with stenosis, masikip, or regurgitation, may backflow. Lalahating ko na, itong tatlong to, MS, MR, AR, kung mapupunan nyo yung location niya, di ba? Mitral valve between LA and LV. Aortic valve, siya ang nag-guard nung blood na papalabas galing sa left ventricle. Kung yan, mga yan, either may stenosis or regurgitation, the end point of the clinical presentation of a patient with rheumatic heart will be left-sided failure. Commonly, the chief complaint of this when they are rushed to the ER, dyspnea, difficulty of breathing. Ito yung mga hindi nag-comply sa every 21 days ng benzathine penG. Nagkaroon na sila ng mga ibang complications. Most of the time, they will again present with dyspnea with or without exertion. Tapos sasabihin nila, ang hirap na matulog, napapagod. Okay? So, for MS, ang maririnig, loud S1 at the apex with narrow pulse pressure, and then there's a diastolic rumble. For mitral regurgitation, so systolic regurgitant murmur at the apex, transmitting or radiating to the left axilla. So, di ba ang VSD, alam nyo, ventricular septal defect, systolic regurgitant murmur dito sa may apex. Pero kapag nag-radiate sa left anterior axillary line, then that is mitral regurgitation. Aortic regurgitation naman, you already have a diastolic murmur. And as we said earlier, diastolic murmurs, all of diastolic murmurs are definitely pathologic. So you hear the diastolic murmur at the upper and mid-sternal left border radiating to the apex, and then you have bounding pulses. Okay. So I hope this table will help you have a consolidation and remembrance of all of these murmurs, no? Yung systolic ejection, as I said, ASD, pulmonic stenosis, aortic stenosis, and even coarctation of the aorta. Ang kaibahan ng mga may stenosis nagra-radiate sa upper back. Ang ASD, no radiation. Systolic regurgitant murmurs, you have VSD and MR. The difference is with mitral regurgitation, there is radiation to the left anterior axillary line. The definitive treatment for those with rheumatic heart disease, aside from taking care of the left-sided failure, is that of course, they have to undergo valvular replacement, no? To replace all of these stenotic and regurgitant valves, no? Or leading to regurgitation. So I hope this has been a useful review of the common congenital heart problems as well as acquired heart problems, such as your rheumatic fever and leading to rheumatic heart disease.